Hello, my name is Dr. Majid Hamid Al Aboud. This is the second lecture of session 5 of the clinical pharmacology module, and I will talk about pharmacology of airway control. In this lecture, we will cover 8 learning objectives. First of all, we will review the module lecture in the respiratory module about asthma. Then we should have some talk about the autonomic innervation pharmacology of the bronchial small muscle. And then we'll talk about the pathophysiology of asthma in order to know how the drug works and know the detail of different bronchodilators, especially talking about beta-2 agonists and methylxanthines, as well as the anti-muscarinic agents. Also, we'll talk about the anti-inflammatory drugs used in treatment of asthma, especially corticosteroids, and then we'll outline the general steps of management of asthma, and then the management of severe acute asthma or life-threatening asthma, and finally, we'll talk in brief about the management of COPD or chronic obstructive pulmonary disease. So, asthma, as you know, is the commonest childhood disease with increasing prevalence in adults. There are millions of people worldwide are affected by asthma, and it is defined as a chronic inflammatory disorder that leads to airway obstruction, which is characterized by bronchoconstriction and mucus plugging. So there is bronchoconstriction due to many reasons, like hypertrophy of the muscles of the bronchi, or because of basement membrane hypertrophy, in addition to the inflammatory process with the over mucus production. Asthma can lead to life-threatening hypoxemia if not treated. Sometimes people may die from asthma, and asthma is a reversible disease, while COPD is not fully reversible, and we said that the reversibility is the main discriminating point between bronchial asthma and COPD. And bronchoconstriction leads to increased lower airway resistance. That's why people with asthma or obstructive lung disease in general will have high residual volume in their lung, and they will have barrel chest. And 40 to 50% of the flow resistance usually is in the upper respiratory tract. So if we want to talk about the autonomic innervation of a airway, you know that we have sympathetic and parasympathetic nervous system. There is a parasympathetic ganglion in the wall of the bronchi and the bronchioles, but there is no sympathetic ganglions in these areas. So parasympathetic innervation usually through the ganglia will innervate the airways and the vascular smooth muscle and the glands that are secreting mucus through muscarinic M3 receptors. On the other hand, the sympathetic nervous system, as I said, are not present in the bronchi and the bronchioles. There is no ganglion, but they innervate the blood vessels and the glands, and there is abundant amount of beta-2 adrenoceptors. And through this beta-2 adrenoceptors, the beta-2 agonists act and they cause bronchodilation. Why? Because beta-2 adrenoceptors in the bronchial wall will cause airway smooth muscle relaxation, and it will reduce mast cell degranulation and will reduce mucus gland secretion. So the parasympathetic system through the M3 receptors are present in the bronchioles, and any stimulation of the parasympathetic system will result in a bronchoconstriction. On the other hand, there is no innervation by the sympathetic system to the bronchioles, but there is a lot of beta-2 adrenoceptors. and adrenaline from the blood will stimulate the beta-2 receptors that are present in the bronchioles, and this will result in bronchodilation. Therefore, if we use beta-2 agonists, we would expect bronchodilation. And if we use anti-muscarinic, anticholinergic agent, we will expect bronchodilation as well. So the mechanism of action is very simple. So from the adrenal medulla, we will have the adrenaline and other substances, and they will act on the beta-2 receptors that are present in the airway smooth muscle. These are the beta-2 receptors, the small black circles, and will cause bronchodilation because they relax the airway smooth muscle. While the sympathetic ganglia that is coming from the central nervous system, and it has its own ganglia, that is the parasympathetic ganglia in the wall of the bronchioles and the smooth muscle of the bronchiole. Through acetylcholine, it will stimulate these muscles and will cause bronchoconstriction. So we learn from that the muscarinic acetylcholine receptors will cause bronchoconstriction and will cause mucus oversecretion, and this will cause bronchial asthma. So again, we have paraganglionic fibers act on the acetylcholine, and here is the ganglion, and the ganglion will release acetylcholine. Acetylcholine will act on the gland to increase the mucus secretion in the airway lumen, and at the same time, it will act on the muscles, will cause bronchoconstriction and muscle spasm. And if you remember from the lecture of asthma in the respiratory module, asthma, whenever a patient who is susceptible to have asthma is exposed to the allergen or the antigen, we will have two types of responses. An immediate response that will occur within 20 minutes from exposure to the antigen, and this is a type 1 hypersensitivity reaction, and it results from the interaction between allergen and the IgE. Therefore, IgE plays a very important role in the pathophysiology of certain types of asthma, and later on we will talk about anti-IgE treatment as part of therapy of bronchial asthma. So as a result of the interaction between allergen and IgE, there will be mast cell degranulation. And after the degranulation of the mast cells, we will have bronchoconstriction. This is the immediate response. Later on, after 3 to 12 hours, we will have the late response. And the late response is a type 4 hypersensitivity reaction, which means it is a cellular reaction, not antigen IgE or antibody antigen reaction. So here we will have a lot of inflammatory cells of different types of these cells, like eosinophils, mast cells, lymphocytes, and neutrophils. They will aggregate together and will induce airway inflammation that will last longer. Therefore, we have to use anti-inflammatory medication, and we will talk about that later on. So whenever the patient is exposed to the allergen, we will get what is called the bronchial hyperresponsiveness. And by bronchial hyperresponsiveness, we mean an exaggerated bronchoconstriction or bronchoconstrictor response to direct pharmacological stimuli, such as histamine, or indirect stimuli, such as exercise. So a patient with asthma, when he has the attack, when he exercises, he will get worse. So a key factor contributing to airway dysfunction in asthma is the bronchial hyperresponsiveness. And the indirect stimuli, like the exercise, will activate mast cell mediators and will induce further bronchoconstriction, and the patient's condition will get worse. Remember always, when we want to talk about the management of asthma, we have two main problems in bronchial asthma. First of all is the inflammation, Therefore, we have to use anti-inflammatory medication. And second, we have bronchospasm. Therefore, we have to use bronchodilators. According to that, we can divide the drugs that are used in the treatment of asthma into bronchodilators and anti-inflammatory agents and the leukotriene antagonists. The bronchodilators, we have the beta agonist, like salbutamol. We have the muscarinic antagonist, and we have the methylxanthines. While the anti-inflammatory agents, we have mainly, we'll talk about the steroids. And finally, we'll talk about the leukotriene antagonist. So what is the mechanism of action of bronchodilators or the relievers, the beta-2 agonist? So as I said, there are abundant of beta-2 receptors in the bronchial wall of the bronchi. Okay, so here we have one of the the beta-2 agonists. It will act on these receptors that are present here, and these receptors will stimulate the GS protein. GS protein will stimulate the adenylate cyclase, which will convert ATP to cyclical AMP. So we will have a large amount of cyclical AMP. This cyclical AMP will increase the uptake of calcium by the sacroplasmic reticulum. Therefore, there will be increased calcium efflux from the cell inside to the outside and decrease the influx of calcium from the outside to the inside. As a result of that, we will have low calcium. This low calcium will stimulate the influx of potassium through the potassium channel. The potassium will get from the inside of the cell to the inside of the cell. And whenever we have high level of potassium inside the cell, this will cause bronchodilation by depolarization. We have many types of beta agonists. We have the metered-dose inhaler, and the name metered-dose inhaler is because it gives a specified dose with each puff. So it's called metered-dose inhaler. And we have the dry powder inhaler, and we have the nebulizer. When we put the substance, the beta agonist, the material in this chamber, and the patient, this is connected to electricity, and the patient will put it on the face. This is a face mask, and he will inhale the nebulizer, the nebulized material. You can see this machine a lot of time in the emergency room, and some people with asthma, they got this machine at home. And we may have beta agonists in the form of IV solution to be given intravenously. And also we have beta agonists available in the form of oral tablets and in the form of serum. But these are not a preferred modality because of the systemic side effect of the beta agonists. They will act systemically rather than locally. And remember, if we give our patient the beta agonist through the metered-dose inhaler, only 10 to 20% will be inhaled into the lung tissue. The other 80 to 90%, unfortunately, will be swallowed and go to the gastrointestinal tract. However, this can be reduced by the use of a spacer, and I will show you later on the spacer. And then the drug that is absorbed in the GI tract will go into the blood and go to the liver, where it will undergo inactivation by first pass mechanism, and some of it will enter the systemic circulation and will lead to systemic side effects. So beta-2 agonists can be divided in general into short-acting and long-acting. And as the name implies, short-acting beta agonists, they act for 3 to 4 hours. This is the duration of action. And we have terbutaline and salbutamol. salbutamol is called Ventolin, is very commonly used. And the long-acting beta agonists, their action will last for 12 hours. So this is the duration of action. And we have two of them, salmeterol and formoterol. So the long-acting beta agonists are very important for the treatment of asthma, and usually they are given in adjunct with the anti-inflammatory, that is the corticosteroid therapy. And usually we use them whenever corticosteroid therapy does not provide adequate control of asthma. And nowadays we have inhalers that contain combination of long-acting beta agonist and inhaled corticosteroid in the same inhaler. And also they are indicated for the treatment of nocturnal asthma. And nocturnal asthma means it occurs in the night, and it is a marker of poor asthma control. So we give long-acting beta agonists in order to control nocturnal asthma. And these beta agonists does not come without side effects or adverse drug reactions. And the major adverse drug reactions include skeletal muscle tremor, especially when we use high doses of inhaled beta-2 agonists. So there will be tremor of the skeletal muscles, or when we use it orally through the oral route. Again, tachycardia is a common side effect, and dysarrhythmia, sometimes there is a disturbance in the cardiac rhythm. We call it dysrhythmia. And despite the fact they are very selective, that is 20 to 400 times selective than beta-1 receptors that are present in the heart, however, beta-2 agonists in high doses can cause dysrhythmia. And there is negative interaction between beta blockers, between beta agonists and beta blockers, of course. An example of beta blocker is propranolol, because propranolol is non-selective beta agonist, beta blocker, and it will block beta-1 and beta-2 receptors. This can lead to severe asthma that is refractive to any treatment with beta-2 agonist, because the receptors are already blocked by beta blocker. Therefore, you should avoid giving beta blocker to a patient with bronchial asthma. Otherwise, you may induce severe asthma in that patient. Now, the second group of bronchodilators is called methylxanthine. And an example of the methylxanthine, we have two. The oral methylxanthine called theophylline, that is available in the form of tablet, sometimes in the form of syrup. And we have the injectable methylxanthine called aminophylline. It's available in the form of vial and given by intravenous infusion. These methylxanthine, like theophylline, will act on the phosphodiesterase enzyme. And you know the phosphodiesterase enzyme will break down cyclical AMP into AMP. So if we inhibit phosphodiesterase enzyme by theophylline, we will stop the breakdown of cyclical AMP. This will result in the increased amount of cyclical AMP, and it will act in the same way of the beta blocker. It will stimulate the efflux of calcium, the influx of potassium into the cell, with the resultant bronchodilation. The major adverse reactions of methylxanthine are mediated via adenosine receptor antagonists. Unfortunately, these agents have neurotherapeutic window. So this means that if we exceed the normal plasma level of these, or the allowed plasma level of these methylxanthine, that is between 30 and 100 micromole, we might get toxicity from these substances. So drugs with narrow therapeutic window, we should be cautious in using them because they might cause toxicity. What are the toxicity symptoms? First, we have psychomotor agitation. The patient will be agitated psychologically and also in the motor system. and second, tachycardia. It's very important to know that theophylline is used in COPD as well, and it is used in status asthmaticus. And by status asthmaticus, we mean like status epilepticus. Status asthmaticus, the patient will have persistent, prolonged attack of asthma or recurrent attacks of asthma within a short period of time. And the patient will not get relief, and very serious condition might need admission to the intensive care unit. The third type of bronchodilators are the anticholinergic or the muscarinic receptor antagonists. And here we have example the tiotropium and the ipratropium bromide. And the mechanism of action is very simple. We said that parasympathetic innervation is present in the wall of the bronchiole, and parasympathetic system will induce bronchoconstriction. So if we block this parasympathetic ganglion by anticholinergic or muscarinic receptor antagonists, we will get a bronchodilation. They act on the M3 receptor. First of all, they will induce smooth muscle relaxation, and they will reduce the mucus secretion by the mucus gland, so they will induce bronchodilation, lower mucus secretion, and hence a relief of asthma. These anticholinergic agents are not in first-line use of asthma. Usually we start with the beta-2 agonist. They can be used to augment the action of beta-2 agonists, and they are indicated in those who are unresponsive to beta-2 agonists during acute exacerbation of asthma. So usually we start with beta-2 agonists. If there is no response, we may give a muscarinic antagonist. And they are also used where beta-2 agonist use is contraindicated in some people. And also we can use them in treatment of COPD. This graph summarizes the mechanism of action of the three bronchodilators. So beta-2 agonist will act on the beta-2 receptors, which will stimulate the transfer of ATP into cyclical AMP, and theophylline or the methylxanthine will block the phosphodiesterase, and this thus will reduce the degradation of cAMP to AMP. Both of beta-2 agonists and theophylline will make cyclic AMP a large amount, and this will stimulate bronchodilation through the potassium, while the muscarinic antagonist will act on the muscarinic receptor and will block these receptors and will block the action of acetylcholine and adenosine, and so it will cause bronchodilation. Now let's talk about the anti-inflammatory agents. We said asthma consists of mainly inflammation and bronchospasm. We talked about bronchospasm through bronchodilators. Now we will talk about how to control inflammation through anti-inflammatories. And the best example of anti-inflammatories is the corticosteroids. Corticosteroids are available for the treatment of asthma in the form of inhaler or in the form of oral tablets, sometimes syrup, and in the form of injectable vials, that is the hydrocortisone. The mechanism of action of corticosteroids is very important because corticosteroids are potent anti-inflammatory. They inhibit all the source, all the types of inflammation in the body. They act on the genes in the cells, the gene transcription, and they will inhibit inflammation through that act. They will inhibit the eosinophil, the T lymphocyte, the mast cells, the macrophages. So they will reduce the amount of cytokines that will induce inflammation. And again, they will act on the blood vessel and the endothelial cells, and they will reduce the leak. And also they will act on the smooth muscles by increasing the expression of beta 2 receptors. So whenever you give corticosteroid to your patient, the number of beta 2 receptors will be increased, and this will make or potentiate or make the action of beta 2 agonists easier, and it will reduce the cytokines. In addition, corticosteroid will act on the mucus gland, and it will reduce the mucus secretion. So now you can imagine the importance of corticosteroid as anti-inflammatory in the treatment of asthma. And like the story with the beta-2 agonists, the inhaled corticosteroid likewise will mainly be swallowed and go to the gastrointestinal tract, and it will end up with the systemic side effects. Therefore, we might use this spacer device. So this spacer device, the idea behind it is to reduce the systemic side effect and by reducing the gastrointestinal absorption. So we put the inhaler in this opening, and the patient will breathe from this side. After pushing the canister here down, the material will go inside and will be distributed in this spacer device. So a large space is in here, and the patient will breathe in the material without being concentrated in his mouth, so it will go to the lung. So corticosteroid, usually we use them in acute asthma exacerbation. So we give 40 milligram usually of prednisolone tablet for 1 to 2 weeks. And they are also used in severe attacks of asthma through intravenous route by giving intravenous hydrocortisone vial. Unfortunately, corticosteroids have a lot of side effects, including croaky voice, sore throat, oral thrush as is shown here in the picture, and oral thrush means fungal infection of the tongue and the mucosal cavity of the mouth. And of course, there are many systemic side effects such as diabetes, hyperglycemia, obesity, osteoporosis, and Cushing's syndrome. However, newer drugs like fluticasone and budesonide have poor systemic absorption, and they are heavily metabolized with a spacer, so we would expect a lower side effect with the use of the newer agents like fluticasone and budesonide. Now, still we are talking about management of asthma and the therapeutics that we have in the treatment of asthma, and we have other drugs like chromoglycate. And chromoglycate is available in the form of sodium chromoglycate, and it is a mast cell stabilizer. So as the name implies, it stabilizes the mast cell, so there will be no mast cell degranulation, and there will be no histamine and other mediators. It is used usually for the treatment of exercise-induced asthma. We give it to the patient 10 minutes before exercise, and it will avoid asthma attack during exercise. Sometimes we may use it for the treatment of asthma. It is given usually 2 to 4 times per day because it has a shorter duration of action of 6 hours with a short half-life of 90 minutes. And we have what is called the leukotriene receptor antagonist. An example of it is the montelukast. And the montelukast is available in the form of tablets, 5 milligram and 10 milligram. And we have chewable tablets as well. The half-life is 3 to 6 hours. And it is metabolized by the liver. And it has a longer duration of action. Therefore, it is given once daily, usually at night, to avoid nocturnal asthma, as I said. And the main side effect of montelukast is headache. And very recently, we have a magic drug for the treatment of asthma called anti-IgE. So we have the omalizumab. And the omalizumab is called a monoclonal antibody. It acts against the IgE. So it is used for people with bronchial asthma with high IgE only. So if you have a patient with asthma but normal IgE, you would expect that this drug omalizumab is of no benefit. But if your patient has high level of IgE, then this should be a good choice. So it is given every 2 to 4 weeks in the form of injection. Usually it is given subcutaneously every 2 to 4 weeks. And we should monitor IgE before the treatment and during therapy, because a good response to anti-IgE is to see a lower level of IgE. The most common adverse drug interaction or adverse drug reaction is injection site reaction at the site of injection, and also upper respiratory tract infection. Why? Because it might inhibit immunity by acting against the IgE. The half-life is very long, it's 26 days, and it is mainly secreted in the bile and metabolized by the liver. The management of asthma is very important. First of all, we have to avoid the triggers of asthma, such as pollen, cold air, exercise, certain chemicals like painting, isocyanides, etc., and the smoking. And we have what is called the stepwise approach of asthma. We have 5 steps in the management of asthma, as you can see here, starting from step 1 to step 5. And when we should start at which step depends on the severity of asthma. For example, in mild intermittent asthma, say asthmatic attack once every week, we may start with step 1. And then if the patient's condition gets severe, we may change into step 2, then step 3, and so on. And this is called the step up. And whenever we are in a higher step, for say in step 4, and the patient is well controlled without asthmatic attack, we may step down by returning back to a step 3 or step 2 or step 1. And this is called step down. So step up and step down. What are these steps? Step 1 is short-acting beta agonist on demand. So if the patient has mild asthma, we give him a bronchodilator inhaler like salbutamol inhaler to be used on demand whenever the patient needs it. While in step 2, we give short-acting beta agonist plus inhaled corticosteroid. In step 3, we will add to these 2 steps, we will add long-acting beta agonist. And step 4, in addition to the previous steps, we add long-acting muscarinic antagonist. While in step 5, usually we give additive treatment like oral corticosteroids. Now, what is the treatment of acute attacks of asthma? What you should do whenever you see a patient with severe asthma in the emergency room. First of all, we should give nebulized beta-2 agonist and ipratropium delivered in oxygen through the nebulizer. And we may give intravenous steroid in the form of hydrocortisone vial IV. And then remember that the patient will have a delayed response, inflammatory response. Therefore, usually we give short course of high-dose oral prednisolone, say 40 milligram prednisolone for 1 to 2 weeks. Sometimes all of these measures will fail. Therefore, we may use other drugs like magnesium sulfate and aminophylline infusion. And remember, life-threatening asthma, the patient may require assisted ventilation and admission to the ICU. We finished talking about the management of asthma, and now we will talk about chronic obstructive pulmonary disease or COPD management. Very important step in the management of COPD is smoking cessation, because you know COPD mainly is due to smoking. So smoking cessation is the most important step. Patient education about the disease and how to live with the disease, how to exercise, how to eat is very important. Pneumococcal vaccination every year is important, because these people are prone to severe pneumonia due to pneumococci. Monitoring of weight Nutritional status and physical activity is important because patients with COPD will be unable to exercise regularly, and this will induce a vicious circle. They will be unable to exercise, they will lose their physical ability because of shortness of breath, and they will have low fitness, and therefore they will have shortness of breath on minimal exertion, and their condition will get worse. Therefore, physical activity is very important, and monitoring of nutritional status, because usually they are malnourished because of the nausea. The use of bronchodilators like beta-2 agonists or methylxanthines or muscarinic antagonists like asthma is important. Inhaled corticosteroid plays a very important role because also there is inflammation and COPD, and we need anti-inflammatory. Pulmonary rehabilitation is very important because as I said, those patients will have shortness of breath. They cannot walk for a short distance. Therefore, we have to rehabilitate them. And the word rehabilitation means in Arabic إعادة تأهيل. And sometimes whenever there is prolonged hypoxemia, we should consider long-term oxygen therapy at home. So we give the patient oxygen treatment for 16 hours at home in order to reduce hypoxemia. Because chronic hypoxemia will induce chronic permanent changes in the bronchi and alveoli, and we will end up with chronic respiratory failure. And like asthma, there is acute exacerbation of COPD. And during the acute exacerbation or the acute attack of COPD, first of all, we have to monitor for hypoxia and hypercapnia, because remember that people with COPD will have respiratory failure type 2. We should give antibiotics because the usual cause of acute exacerbation of COPD is infection or pneumonia. We give nebulized bronchodilators. We give oral steroids like in asthma. And we should use a low concentration of oxygen, that is 24% to 28%, because these people will have type 2 respiratory failure. And finally, in severe life-threatening COPD, just like in asthma, we might need to admit the patient to the intensive care unit and consider non-invasive ventilation. And thank you for listening.